Welcome to the Critical Care Obstetrics Podcast. My name is Suzanne McMurtry Baird, the Nursing Director, and I'm here with my partners, Julie Arafeh, Simulation Director, and Stephanie Martin, Medical Director at Clinical Concepts in Obstetrics. Today, we are responding to questions from our listeners. This is our fourth time to answer your questions. So we put out this request for questions and heard from so many of you. And again, our fourth attempt to try to answer those questions that you've sent in. So thank you so much for listening and sending us these topics. Today, we're going to talk about two topics that we heard request for, and it was something that we'd previously talked about, but obviously there's still questions about some of the content and some of the care initiatives around ARDS, or acute respiratory distress syndrome, and cardiomyopathy. We lumped these two together because this two different diagnoses, different pathophysiology, are under the umbrella of cardiogenic and non-cardiogenic pulmonary edema. So cardiogenic being fluid volume overload, and non-cardiogenic pulmonary edema, meaning the pulmonary vasculature has been damaged in some way. So there is injury to the pulmonary vasculature, fluid leaking out. So these presentations, in other words, are very similar.
Yeah, and just to kind of follow up on that, if you just look at the name, cardiogenic and non-cardiogenic, one is all related to the heart not being able to handle the volume, and the other one has nothing to do with the heart not being able to handle the volume. So everything's going to come down to pulmonary edema. Is it because of the heart or not because of the heart? So that's going to drive your evaluation. It's going to drive your differential diagnosis. It's going to drive your workup. It's going to drive your treatment. It drives everything. So two things you hear from us talk about a lot, but it bears repeating here. We don't like pulmonary edema. Say whether it's cardiogenic or non-cardiogenic, and that really starts to cement it in your head. And don't use the term heart failure.
Oh, that is the worst. Even the ICU docs and clinicians, that term is just nondescript. It's like an umbrella for something's going on, but we don't, it's just so vague and ambiguous. So just be more specific. So that was one of our big points, I think, with this lecture, is that one's a heart condition, okay, but they both affect volume in the lungs.
So I hear you guys talking about cardiogenic and non-cardiogenic pulmonary edema, and I remember how long it took me to understand the difference between the two. So what I was wondering if you could do is, because you do this so well, can you describe what the signs and symptoms are that would lead you to think cardiogenic versus non-cardiogenic pulmonary edema?
Well, I think it always goes back to the assessment, and we begin there. And it is so important with these two different types, because Julie, you and I were at the bedside together, actually, with patients who had Swan-Ganz catheters in place. And I remember, again, those times where we would say, I'm thinking, based upon my assessment, that this patient has a cardiogenic or a non-cardiogenic pulmonary edema. And we got better at guessing, because essentially that's what you do until you get either an echo or you have an invasive hemodynamic monitor placed, like a Swan-Ganz catheter. So the presentations can be very similar. So both of them have hypoxemia. Both of them are short of breath. And then our differential starts to really take effect when you start doing more in-depth assessment.
So when you've got a patient with hypoxemia, you're really thinking about four things as a potential explanation for what could be happening. Four things on your differential: pulmonary edema, pulmonary embolism, asthma, or pneumonia. And we're focusing on pulmonary edema here, but when you've got hypoxemia, you've got to think of one of those four things. And in a pregnant and postpartum patient, the overwhelming majority of things are going to fall into one of those four categories. So your workup is driven by this differential. And then when you determine it's pulmonary edema, then you're going to do workup that's driven at figuring out whether or not it's cardiogenic or non-cardiogenic.
And out of those four, pulmonary edema will be the top contender that I'm thinking about when I have a patient who has hypoxemia, either in pregnancy or the postpartum period. So.
Agree. And asthma should be the very bottom of your list. Unless your patient has a known history of asthma and asthma exacerbations, that is going to be the least likely, probably PE and asthma together. And don't assume that your patient has a new diagnosis of asthma that's significant enough to cause hypoxemia that she's never known she had before. That's not a thing. Okay. Asthma doesn't just show up in pregnancy. They have pre-existing. So PE, pneumonia, pulmonary edema, and then asthma at the very bottom.
So then when you start looking at the differential cardiogenic fluid volume overload versus non-cardiogenic pulmonary edema, then you start getting down into that assessment, those nitty gritties. So cardiogenic, think about, let's do that one first, because that one to me is the easiest to detect because volume is going to be overloaded. So much volume in the heart, it's backing up into the lungs. So these patients are intravascularly wet. They have bounding pulses. They have wide pulse pressures. They have evidence of excessive volume. So they could have right side failure, meaning it backs up into their system. But that's usually not the clinical picture in our patients. Is they don't make it that far, okay? But they usually have some kind of excessive volume. Their lungs are full and they fill up from the bottom up. So the crackles begin at the bases and then the crackles move all the way up to the top of the lungs.
And I think people get really hooked up on this because they listen to the lungs, don't hear crackles, and rule out pulmonary edema. You can't rule out pulmonary edema because you don't hear crackles. Crackles are not a necessary component of the diagnosis of pulmonary edema of either kind. Crackles are commonly heard, especially with cardiogenic pulmonary edema, when the lungs are soppy and wet and the alveoli are collapsed or full of fluid and there's fluid bubbling in it that you're hearing when you listen. But you can have swelling of that membrane between the alveolus and the blood vessel that impacts oxygen getting from the alveolus into the bloodstream, but you're not going to hear that. You're not going to hear it. So crackles are not necessary to diagnose pulmonary edema.
I think it's actually a late sign.
Yeah, a later sign. I think too, again, just getting back to the way we assess, I've seen too many mistakes. Number one, listening to just anterior breath sounds, sitting the patient up in the bed and listening posteriorly throughout the lung fields, so important. And that means stethoscope to skin too, not over the gown. I think that gets in the way. Any kind of movement of your stethoscope, can really decrease your ability to hear, especially if the crackles are fine, then you will if you just go skin to stethoscope posterior and really listen. Because again, the fine crackles are much more sensitive. It's harder to hear, It's like rubbing that hair between your two fingers by your ear. You hear that just very delicate crackle. So those patients, again, that assessment, hypervolemia. Also, you could have hypertension with cardiogenic pulmonary edema, especially your systolic value will be higher. And that's what drives up that pulse pressure in between the systolic and the diastolic is that volume, excessive volume. Their urine output will usually be abundant, clear, not concentrated, those types of things. So, my two favorite, pulse and urine, those are my two keys. Non-cardiogenic patients look completely different. Their pulses are weaker. They don't have a volume overload. Remember, it is just strictly related to damaged blood vessels within the pulmonary vasculature. So weaker pulses, you would have a narrow pulse pressure because that volume is leaking out in third spacing. They will have edema because of that leak. It is going out into the extravascular space. And then also their urine output starts to drop because as their intravascular volume depletes, so does perfusion to the kidneys. Urine output drops, and the kidneys then start to reconcentrate or concentrate the urine.
This is a random factoid that maybe other nerds like me will appreciate, but third spacing. So
Okay.
what's the third space, right? So the first space is intracellular. The second space is intravascular. And the third space is not in either of those two places. It's extravascular and extracellular. So when we say someone's third spacing, it means they're not holding fluid in their cells and in their intravascular space. So it's leaking out into the tissues. So I just think that's kind of interesting. We just kind of get used to these terms.
Okay, I've never heard you say that, so thank you.
But I think it's a good point because I know for me, when I was learning this, it took me a long time to get this information. So I just want to reemphasize for those of you, the way that I look at this is I think about carrying a bucket of water. And cardiogenic pulmonary edema is a bucket of water where the water is sloshing over the top. It's so full you can't hardly carry it. And non-cardiogenic pulmonary edema is carrying a bucket that is full of holes, and the water is just spilling out in all directions, no matter how much you try to contain it in that bucket. So what Suzanne is talking about, she is talking about increased nursing surveillance of a patient. And I think oftentimes I will say this, but I don't know if people really understand what that means. And it is just what Suzanne described. You don't have to surveil a patient who has a normal blood pressure, normal pulse, normal pulse oximeter reading this way. Everything is normal. You've got a category 1 tracing. Everything is fine. Or the postpartum patient's up walking around, nursing her baby, not having any issues, but it's the symptomatic patients that you have to delve deeper to figure out what the problem is.
I love your analogies, Julie, and now I know what third spacing is. I know where that is, and now your analogy. So I thank both of you. I always learn too. I love that analogy. Okay. So let's talk about some more
I'm
differences.
stealing that one for my next talk, Julie.
I know. Me too. Me too. I mean, I love that. Okay, let's talk about some of the other differences. So chest x-ray. Stephanie, you want to hit on that?
Yeah. So if you think about everything that we've been talking about and that Suzanne's described with cardiogenic, where the heart, the fluid is overflowing from the top and filling the lungs, it's going to fill it from the bottom up. So on x-ray and on exam, your changes in the lungs are going to occur at the bases and then rise to the top. So it's like filling that bucket with water. It's going to fill the bucket first at the bottom and then rise to the top. Whereas with non-cardiogenic pulmonary edema, this is diffuse damage to all the blood vessels in the lungs, whether it's bases or apices. So these changes, this fluid and they look more fluffy kind of damage that you'll see on an x-ray. It happens bilaterally and diffusely through the lungs. The other thing you'll see with cardiogenic is evidence of wet, soppy lungs that are just overloaded. So you might see effusions, pericardial and or pleural effusions. You might see fluid in the fissures. That's called a Curley's B line. So you'll see evidence of fluid not just in the lung tissue itself, but also around the lungs. And that can definitely help you discriminate between the two. Ultimately, you're going to have to do additional workup to figure it out, but those are the clues that are going to make you think this is what could be going on.
Yeah, the other difference is when the chest x-ray really shows up. So in a cardiogenic pulmonary edema patient, you're going to see chest x-ray changes quicker. You're going to see those soon, and they actually have less hypoxemia versus the non-cardiogenic patient. They have really high, their hypoxemia is more severe, and their chest x-ray is a little bit delayed, and it may be up to 24 hours delayed.
And some people are listening going, but wait a minute. I've had patients with cardiogenic pulmonary edema have really severe hypoxemia. In our experience, at least my experience, they get that severe because we ignore the mild and we let them get that severe. We tolerate mild degrees of hypoxemia. We just give them a little tweak of oxygen, 1, 2, 3 liters, and they respond, and we don't think anything of it. And then all of a sudden, we can't keep their sats up anymore, and now they're severe. So we've ignored the early signs and let them get to that point.
I think this whole discussion with the chest x-ray is really important to think about looking at the patient. You can look at the chest x-ray, and I know this has happened to me several times, is that the patient looked great, but the chest x-ray looked awful. So I think you always have to look at the patient.
Well, or the opposite. The patient looked really bad. She is extreme hypoxemia and it's getting worse. And you do a chest x-ray and it looks fine. And to me, that's a clinical clue that it's non-cardiogenic pulmonary edema. And the next day they do another chest x-ray and it's wide out. And that is non-cardiogenic.
Yeah, so you have to be suspicious because you have to repeat the chest x-ray. Too often we see them do a chest x-ray, it's quote normal, and then the response is, oh, well, we don't know what this is, and nobody continues to follow it up. We just continue to supplement with oxygen.
Or worse, you extubate the patient. So, you've had this, patient that's been decompensating and she was, in the OR under general anesthesia and she gets extubated without the anticipation that her chest x-ray will get worse. So we've talked about that before with DIC and with hemorrhage, is that you anticipate that patient may go into a pulmonary edema at some point.
So that kind of transitions us nicely into ARDS, because someone asked, what are some early signs to recognize ARDS? And we've been talking about them. ARDS, the early phases of ARDS is going to be hypoxemia. It's going to be non-cardiogenic pulmonary edema presenting with hypoxemia. The difference with ARDS as compared to like cardiogenic pulmonary edema, other than everything we've already been talking about, is that with ARDS, you have to have an inciting event of some sort, which leads to lung injury. Now, in our world, we're talking about preeclampsia, sepsis, DIC, hemorrhage, pneumonia, COVID, could be trauma. Like anything that can cause lung injury can lead to ARDS. It doesn't have to lead to ARDS, but it can lead to non-cardiogenic pulmonary edema, which if not addressed, if the underlying cause is not addressed and the hypoxemia improved, then it can lead to ARDS. Now, ARDS has a very specific definition, but very simply put, it's lung injury. So you've got some sort of inciting event, a pneumonia, a DIC, whatever, that led to damaged alveoli and inflamed lungs, which ultimately leads to impaired gas exchange. That's the hypoxemia that you're seeing. Ultimately, it will lead to stiff, non-compliant lungs and high blood pressure in the lungs or pulmonary hypertension. So an injury related to an event, which leads to issues with gas exchange, damage to the alveoli, stiff non-compliant lungs, and pulmonary hypertension.
Yeah, and the most common cause is, to re-emphasize that, in a pregnant or postpartum patient, preeclampsia, which is a multi-system organ dysfunction and damage to organ systems, capillary leak, same thing with sepsis, and then DIC. Any condition that led to DIC, which could include hemorrhage or sepsis and or preeclampsia. So if you get those three down, you're going to cover most patients that develop non-cardiogenic pulmonary edema, and then, if not addressed, ARDS in our population.
So you're going to suspect non-cardiogenic pulmonary edema if you've got hypoxemia in the setting of any of these things that we've been talking about. Some other clinical clues are going to be your assessment findings that we've talked about, lagging chest x-ray findings compared to their degree of hypoxemia. Maybe she's got an increasing oxygen requirement, which that can look like, you're upping the O2 just to keep her sats where they need to be. And that could be nasal cannula, face mask, whatever. It could be that she just rolls over in bed and her sats plummet.
That
Minimal
is
activity.
A really sick patient too. When that happens, you roll that patient over and she desaturates. We used to call that one thing. Do you remember what we called it, Julie? FTD. And it wasn't the flower arrangement. FTD, you know what that stands for? You know what we used to say? Fix it to die. Mm-hmm. Just fix it to die.
Never normalize hypoxemia. Never normalize hypoxemia.
Yeah, it's not the time to go in there and go, it's time for your bath. We're going to give you a bath and we're going to, do all these interventions with you, because those patients are so unstable. If their oxygen requirement's that high and they don't have any reserve, that's where your oxygen reserve conversation comes in. They have no oxygen content and availability to transport to the tissues.
And this is exactly the time when you need to notify the physician. If you're the bedside nurse, you can't just say this patient's hypoxemic. I think you need to be a lot more descriptive than that. Utilizing respiratory rate counted for a full minute, utilizing the pulse oximeter, and how the oxygen has escalated. So it's important to particularly in these patients that are starting with these subtle signs, to be very descriptive in what you're seeing when you're talking to the physician.
Yeah, and these patients will have that look too. They're going to be, their oxygen need is so great that they are not going to tolerate lying down in the bed. They're going to be sitting up in the bed, leaning forward, using their accessory muscles to breathe. They are struggling, and you are getting that team to the bedside quickly because this patient is getting ready to decompensate further.
And getting the anesthesiologist involved as early as possible is going to be important. Right,
because they're going to be your team member that intubate and respiratory therapy too at the bedside. So these patients are extremely sick. Stephanie, why don't you talk about a little about PF ratio, because I think that's so important of a concept when you're talking about non-cardiogenic pulmonary edema and ARDS.
Yeah, so the PF ratio, it can get real intimidating, and you may have never heard of it, or you may have heard of it and wonder what it is, but essentially it's a way to know if the oxygen, how much oxygen you're giving is getting through into the bloodstream. So a quick review. When you breathe in air or oxygen, room air at sea level is 21% oxygen. The first thing that happens is that oxygen goes across into the alveoli, across the membrane, into the blood vessel, and then it saturates hemoglobin, 100%. And then once hemoglobin is fully saturated, any leftover oxygen gets dissolved into the bloodstream. That is your PO2 that's measured with an arterial blood gas. So that PO2, that dissolved oxygen in the blood, is just waiting to refill the hemoglobin molecule as it desaturates. So anything can cause it to desaturate. It can be delivering it to the tissues, you can have activity, whatever, but your PO2, your dissolved oxygen, is just ready to fill up those hemoglobin molecules. So once your hemoglobin is fully saturated, any extra oxygen you give the patient has to get dissolved. And so your PO2 is going to go up, 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 up. Normal at room air in a pregnant patient is going to be somewhere in the 100 range. Okay. That's normal. But if I give a normal patient without any lung disease at all, if I were to give her supplemental oxygen, her PO2 is quickly going to go to the 300, 400, 500 range easily. Okay, because it's just all this extra oxygen just sitting there because the lungs are letting it get across into the bloodstream. So looking at your oxygen saturation is just one piece of information. If you can't even maintain saturations above 95%, by definition, your PO2 is very, very low. It means there's not enough oxygen getting through into the bloodstream to keep that hemoglobin molecule saturated. So I know what your PO2 is. But what about when your PO2 is 100%, 99% on oxygen? Now I can do an ABG and say, how high is the PO2? How much extra oxygen is getting across? So the P is the PO2 that you get from measuring an ABG, and the F is the FiO2, which is just the amount of oxygen that's being delivered or breathed in. So if she's on 100% oxygen, the FiO2 is 1. If she's on 50% oxygen, the FiO2 is 0.5. So this is why when you draw an ABG, they always want to know how much oxygen she's on. It's so you can calculate the PF ratio. High numbers are good. Low numbers are bad. If you get below 300, we're worried about problems with diffusion. If you get below 100 and you meet all the other criteria, you have severe ARDS. So it's a measure of just beyond the saturation. You've all had that patient who's satting 100% on, CPAP, BiPAP, yet she's struggling to breathe. She's feeling incredibly short of breath. Her respiratory rate is 38, but her sats are 100%. First of all, she's got major issues maintaining the work of breathing, but her PO2 may not be high. She may just barely be getting enough oxygen across to saturate hemoglobin, but nothing else. So that's just a nutshell of PF ratio. Super, super helpful, especially when you think you've got a patient with ARDS.
So now management of ARDS is really about support and protecting the lungs while they heal. The lungs are injured. The lungs need to heal. It takes time for the lungs to heal. And until you remove that cause, then the lungs stay damaged. So for example, preeclampsia. You're not going to see the lungs improve until the preeclampsia starts to resolve. Same thing with sepsis. The patient remains septic or in septic shock, then the cause is still there. So it takes time after you've dealt with the patient's cause. Hemorrhage, another example. We anticipate if they've had massive hemorrhage and DIC, we're going to anticipate a non-cardiogenic pulmonary edema, acute lung injury. That could be from the cause of the DIC in and of itself. It could also be a cause from blood product administration. So either one can cause a non-cardiogenic pulmonary edema, which I think that we have to anticipate again with those patients.
And to your point, Suzanne, management of this is about support and healing. It's not just Lasix. If you just throw Lasix at every pulmonary edema patient without understanding the cause of their pulmonary edema, you're going to harm people. Because patients with non-cardiogenic pulmonary edema are intravascularly depleted. Now, there may be a role for Lasix in these patients, but it's with the understanding of what their intravascular status is, what their lung status is, what their renal status is, all of those things. It's not just give them Lasix to get fluid out of the lungs. First of all, the fluid in the lungs is thick, high protein. Think mucus, think pus.
Yes.
It's inflammatory liquid. It is not water. It's not going to respond to Lasix in the same way that your cardiogenic pulmonary edema patient will. So,
Right.
I mean, I use a lot of analogies like Julie, and I think of ARDS like you've broken your ankle, okay? So I can't just put a cast on and your ankle is healed. I have to put the cast on, not walk on the ankle, and wait for the ankle to heal itself. The lungs have been damaged. I can't just put you on a ventilator and get rid of your infection and your lungs are magically better. I'm going to make sure I don't beat the crap out of them with a ventilator. I'm going to make sure I don't damage them further with a ventilator, at least as much as I possibly can, while I let them heal. And that takes time, not days, weeks, maybe months, long time. So,
Right. Just don't get too antsy. And I think one of the big mistakes in our OB world that we talk about with pulmonary edema, and we've talked about this before, is that, again, we don't anticipate that maybe this low-risk patient could then become high-risk, could then become critically ill. She's just there to have a baby, right? Or she's just pregnant. And then they do. And so we want to make them better quick. Like they can't be this critically ill. And so let's get her off the vent. So we take them off the vent too early when their lungs aren't healed. So again, don't rush. If they're not healed, they're not healed, and that takes time. And it all depends. It's all individualized too. It's not a specific time period. Okay.
So maybe now is a good time to switch to cardiogenic pulmonary edema, because we got some questions about cardiomyopathy. Like, just help us understand cardiomyopathy. And I think this is a really good question, because I think we get confused about this in a pregnant patient. So, Suzanne, what do you think?
Well, it's a non-specific term again. Cardiomyopathy has so many potential underlying etiologies. And it again may get clumped into that term of heart failure, that these patients are in heart failure, and they are. But again, what is the cause? And I think the important thing in OB, if you're practicing an OB and seeing these patients, is that we have to get cardiology and MFM involved, that we need that duo to figure out the etiology, because there are several in our pregnant population.
Yeah, and not all cardiologists and MFMs are created equal. So having a cardiologist on staff at your hospital is not the same as having a cardiologist who's willing to come in at the bedside after hours and see a pregnant or postpartum patient. And understand that not all cardiomyopathy in a pregnant patient equals peripartum cardiomyopathy. They are different. And the same for MFMs. Like, Julie, you made the comment about, some MFMs are really ultrasound experts and are not comfortable in this arena. And that's very, very true. But I would challenge those of you listening that if you don't have access, if you've got a patient with cardiogenic pulmonary edema and cardiomyopathy, and you don't have a cardiologist and a maternal fetal medicine physician who are willing and able to manage these patients, then I would argue she may be outside the scope of care for your facility. I don't care what level you are.
Right. And we've seen that when we've consulted with hospitals. They may have an MFM that they use and practice for their service, but that MFM may not take care of patients inpatient. They may not come to see them. They may not be involved in their care. And the same thing with the cardiologist. And the cardiologist has not seen inpatient pregnant patients at all. So we need to know that. And that's where your scenario and practicing that response to the patient that presents is so essential to understand not just your scope of care, but who will respond if we have a patient, such as a patient with cardiomyopathy at our facility.
Yeah, I actually had a patient recently who has atrial fibrillation. She's somewhat symptomatic right now, even though she's early in pregnancy. But even though she hasn't had any documented AFib episodes, she's felt like she might have. But she has a watch and she's hasn't documented any. But nevertheless, she was scheduled for an ablation for this, and then had a positive pregnancy test, so the ablation procedure was canceled. And she came to me and was very concerned because her cardiologist is terrified of her now. Like, she's like, he doesn't know what to do with me. She feels insecure being with him because he feels very insecure with the fact that she is pregnant. And so we had a conversation about, well, where do you want to have your baby? And do you want to see a different cardiologist? Because I'm an MFM and I'm very comfortable in this arena, but I know my limits and I cannot manage your AFib without a cardiologist. I mean, I know a lot about AFib, but I don't know as much as I need to know about AFib. I am not a cardiologist. I need a team member who can help me with that. So it doesn't matter how good you are, you need partners in care. So we referred her to another cardiologist who I know will be comfortable with a pregnant patient, and that will make the patient more comfortable, and it will be better for her care and make her pregnancy and her birth and her postpartum period safer altogether.
Well, and to hear that from you is so impressive because you have everybody respects your knowledge of these complications in pregnancy and the maternal side of things, Stephanie, and I appreciate that you don't just keep those patients to manage yourself, that you recognize where you need that help. And I think that for our OB population especially, that we need more of that. I really think that would make such a huge difference in our outcomes if we as hospitals or we as clinicians recognized where we need help.
These are definitely patients that need a community. They need a community of providers. And if you look back to the cardiac checklist that the both of you developed with the American Heart Association, it clearly describes that community in great detail and what that community does in each of its parts. And that checklist can be found in our advanced concepts, in our critical care obstetrics academy. So that will be a valuable resource if you have these kinds of patients, to really plan care and see what all the pieces and parts need to be.
Yeah, and Suzanne and I were fortunate enough to be invited by the American Heart Association to work on some education modules around cardiovascular conditions in pregnancy. And one of those is with cardiomyopathy. It's a combination of videos that are on YouTube, on their YouTube channel, on their Twitter account with some, they call them tweetorials, which is, I love that.
I know.
And other stuff that's also hosted on their website. We'll put all the links to that in our show notes if you guys are interested. It's all free. It is aimed at providers. It's cardiologists, nurses, maternal fetal medicine, a real doula. It's a real interprofessional group of people talking about all these topics. So,
yeah, there's a lot of resources there, but specifically, a lot of it has been around cardiomyopathy. So take advantage of that free education. And I believe there's CE involved too. So that's free.
Yeah. So cardiogenic pulmonary edema, we've covered a lot of this already. Your evaluation is going to help you determine what type of pulmonary edema your hypoxemic patient has. I think as we wrap this up a little bit, our key take-home message with respect to cardiomyopathy, not all cardiomyopathy in pregnancy is peripartum cardiomyopathy. This peripartum cardiomyopathy has very specific criteria, including that it is a cardiomyopathy, an ejection fraction less than 45%, in the absence of any other explanation. Okay, the decreased ejection fraction that you see in your patient with septic shock, the decreased ejection fraction that you see in your patient post-resuscitation is not peripartum cardiomyopathy. You have another identifiable cause. So not all decreased ejection fraction is peripartum cardiomyopathy, okay?
I've seen that a lot in preeclamptic patients where we'd see decreased ejection fraction and they would get diagnosed with peripartum cardiomyopathy, and it was preeclampsia.
I think even just thinking about what we've talked about today, the whole issue of hypoxemia and shortness of breath is the perfect topic for an algorithm, because you're not going to remember all of these things the next time you're faced with this. But an algorithm kind of laying out what we've talked about today, it will be a great reminder to have at the bedside. So these are the types of things that you don't need to keep in your head, but you need to know where your resources are so that when you're faced with them, you have what you need to do the best thing for the patient.
And we have that algorithm that we developed for pulmonary edema in our course, in the Advanced Concepts course of our Critical Care Obstetrics Academy. So, and it's a free download, and I think it's helpful. I think it goes over everything that we've talked about as far as symptoms and diagnostic.
It's an included download if you purchase the course.
Right. Yeah. Thanks for differentiating that. We need an algorithm. But one of the key things as far as the diagnostic that you're going to want to use, it will be echocardiogram. And an echocardiogram can differentiate for both of these diagnoses. It'll not only give you your pressures within the heart, but it will also look for any kind of structural issues that may be going on as a cause. And it can also look at that ejection fraction.
And if you can't get an echo in your facility, then I would argue this patient is probably outside the scope of your care.
I would say they are outside their scope of care. So
those of you listening thinking, yeah, but that's all fine and good, I can't get an echo. Well, then you're calling for transport. That's
right. I mean, and no, the patient can't wait until Monday morning when that is available at your hospital, because during that time she could decompensate more. So I hope this has helped. We've given you some resources, and we have talked about those two questions of ARDS and cardiomyopathy. Point you back to two previous episodes of our podcast. One is specifically on pulmonary edema that Stephanie and I did, but also there is more on cardiomyopathy. And I think this is really getting into a huge issue that we're seeing, because cardiomyopathy obviously is one of the top reasons that mothers die in the United States. And I think it's not that we're seeing more of it, we're just diagnosing more of it. So again, that's an important concept. So we hope that this has helped. So thank you for listening and shooting us those questions. Don't forget to subscribe and leave us a review and leave us comments. We want those comments and that feedback from you. You can learn more about the Critical Care Obstetrics Academy that we've mentioned several times at our company website, and that is at www.clinicalconceptsnob.com. You can also follow us on our Facebook page, Clinical Concepts in Obstetrics, on LinkedIn, Clinical Concepts in Obstetrics, and on Instagram at Critical Care OB. And you can also then go to our website also and email us and send us a direct message for suggestions on future podcasts. Thanks for listening, and we'll see you next week.
This podcast was produced by Austin Baird. Are you looking to create a podcast? Please email me at podcastnashville@gmail.com. That is podcastnashville@gmail.com.